Hello and welcome to Health Styles. I'm Connie Mead. We all know that as human beings, our ability to converse is fundamental to our existence. Conversations enable us to learn, to help us get our jobs done, to care for our families, and to build relationships. While some conversations are very simple and easy, such as what's for dinner tonight, others are quite difficult. And today we focus on one of those more challenging conversations that we all need to have, informing our loved ones of our preferences for medical treatment in the event that we're incapacitated and can no longer make medical decisions for ourselves. So today we turn our attention to that question, and we also learn about a new initiative taking place over at Lowell General Hospital that addresses this question and kind of jumpstarts this conversation for the community. Joining me today for our discussion is Gagne, who is the Director of Mission and Chaplaincy at Lowell General Hospital. So I want to thank you for coming in today and welcome to the program, Carol.
Thank you, Connie. It's a pleasure to be here.
Okay, well, great. So you are the Director of Mission and Chaplaincy at the hospital. Can you tell us what your office does over there and how it fits in to the hospital?
I'm responsible for the palliative care program at the hospital and the spiritual care program at the hospital. So spiritual care is the chaplains who go and visit our patients and offer comfort and prayer and support to patients and families. The palliative care program really deals with patients who are suffering from any life-threatening or life-limiting illness, any chronic illness that eventually could become a terminal illness at some point, to help them stay well and stay healthy as long as they possibly can.
Okay, so does that involve just more kind of psychological support or spiritual support, or is there medical support involved in that as well?
It is medical support. It's actually a team approach to health care.
I see.
So there is a palliative care nurse, there's a palliative care physician who oversee the medical care of the patients, but we also have pharmacy involved and nutrition, and spiritual care is obviously involved as well.
Okay. And then you say, too, that you run the chaplaincy as well. So that involves all the are there outside chaplains that come into the hospital?
All of the chaplains work for the hospital.
I see.
So there's chaplains at both of our campuses, the Saints campus and the main campus.
I see. And can you tell what, what kind of faiths do they minister to, the chaplains?
We represent different faiths, traditions ourselves, but we minister to all of our patients in the hospital. Okay. So regardless of their faith tradition or patients who have no faith tradition, we're there for support. Really, and we're not there to convert anybody or to bring a particular agenda. We're there to meet the needs of the people where they are.
I see. Okay. I'm just thinking that Lowell's such a diverse community that you must have many different faiths represented among the your patients.
We do. We have Christians and Jews and Muslims and Hindus and Buddhists, and so we're trained in knowing a little bit about every single faith tradition, and our patients are wonderful guides in helping us to know what it is that they really need so that we can be of service to them in the crisis of being admitted to a hospital.
Okay, all right. And now, how did you get involved in this kind of work? Can I ask you that, or is that too personal?
No, it was a personal calling to do something with my life that was going to matter, that I felt at the end of the day I could leave work knowing that I had made a difference by showing up for work every day. And so I really felt called to do some type of ministry, and chaplaincy seemed to be the place that I was guided to.
Okay.
And I've been doing it now I just started my 19th year.
Oh, Okay.
of chaplaincy. Not all of it at Lowell General, but at other hospitals as well.
Okay, well, great. Okay, so well, it's good to just have that kind of overview. Now, one of the programs that you've started and why we're here today is to talk about something called Connecting Conversations. Is
Yes.
that right? Okay.
Exactly.
So what is that program you've started?
Well, Connecting Conversations was our attempt to get people to talk about what is a difficult conversation, as you mentioned in your introduction, about end-of-life care, because we see so much of that at the hospital. And when patients are in the hospital and their families are there and it's a crisis, that's not the time to be entering into those very personal and very difficult conversations. There's a lot of emotional things that are happening at that point, and people aren't always in the best emotional place to be thinking clearly about what they would or wouldn't want. And often we have families who come in who have no idea because they've never talked to their loved one, or if they've tried to talk to their loved one, they didn't want to have that conversation. A lot of people want to avoid it. So then they're in a situation where now we have to make a decision and we don't know what our loved one would want us to do. And that's a very difficult place to be. It's very, very hard.
Okay, so do you see this happen often?
We see it happen almost on a daily basis.
Okay, all right. And so the patients themselves have not had the conversation, or and so there are no documents in place because you need documentation
Yes.
to follow through with any plan. Is that correct?
It is, and oftentimes people think that just by naming someone as a healthcare agent or their healthcare proxy, that suffices, but they've never sat down and had a conversation with that person about what they would really want. And that puts that person in a very difficult position of not knowing what this person wants them to do. And having to make a real life and death decision can be very difficult for someone, and it's emotionally challenging, and we want everybody to walk away feeling that they did the very best that they could for their loved one and not carry a lot of guilt about or questions, what should I have done something different?
Okay. So when you have a situation like this, what usually happens? That the patient has become incapacitated, maybe a car accident or some other kind of or health emergency.
Right.
Makes them incapacitated, and then doesn't normal hospital care take over? I mean, in any case, the emergency room would do what they need to do.
Absolutely. We would always take as best care as we can of every patient who comes through our emergency room or through the doors of the hospital, but we would turn to the family when it's a very critical situation and ask for guidance and ask them to tell us, how far do you want us to go? How much do you want us to do to your loved one? Would you think that they would want to be kept alive on artificial means? And for how long would you want us to do that? So the family then is in a crisis already, and they're being asked to make very difficult decisions, and it's a challenging time.
Right. So it often involves whether to use life support.
Absolutely.
And continue the life support is what you're really getting at here.
It is. It is.
Okay. And then life support can take the form of what?
It could be being hooked up to a respirator, which will be a breathing machine that will breathe for you if you cannot breathe on your own. We can use all kinds of medications to help maintain somebody's blood pressure if they're not being able to do that themselves. Their heart rate, we can try to control that. We also might have to insert a feeding tube if people are not able to take nourishment for themselves. So those are very difficult decisions to make.
Okay, okay. Interesting. So now what you've done, though, is in addition to, I mean, you already have that program in place, I mean, that you talk to the family, but now you have this caring conversations or connecting conversations where you're using a novel to help bring this message home to the community, correct?
Yes.
So tell us about that.
Okay. A couple of years ago, I came across a little ad saying that Jodi Picoult, who is a pretty famous author, and she lives locally, that she was coming out with a new book, and that the topic of the book, it's called Lone Wolf, is about a situation where a gentleman who's not very old actually, in his early 50s, and he suffers a traumatic injury in an accident. And due to the family circumstances, his two children, one is a teenager, and one is an older son who's in his 20s, and they are now put in the position where they have to decide whether or not to continue to keep him on life support or not. And the two children are at opposite ends of the decision, and the story unfolds from there.
Okay, and what about his wife?
He is divorced,
Okay.
and she has remarried. So for that reason, she does not have any legal right to be part of the conversation, to get any of his medical information because of the HIPAA guidelines.
Okay, so it's up to the two children to
Yes.
make a decision because the question is whether or not he should remain on life support.
Exactly.
Okay.
Exactly. And because they disagree, and because there's information that's not always brought out into the forefront, the two children really battle it out. In fact, actually taking the situation to court and asking the court to make a decision as to who should decide what to do. As the story unfolds, we find that there are parts of inside each of them that they have not shared with other family members or with other people in the decision-making process. And as those pieces of the story start to unfold, we learn that there's reasons why each of them is holding to the position that they have.
Right. So in a situation like this, and this could happen in a family too, that when you're put in this situation, certainly your emotions run high because the person is in a very critical condition, but then everybody kind of brings their own baggage along with them, correct? What they have
They do.
unfinished business with this person.
So one of the things that we work really hard on is helping to uncover what those hidden agendas might be and helping people to see how that's impacting their decision-making process. And a lot of times it's a lot of guilt that people are carrying around because a relationship hasn't been healthy, or there may have been an estrangement in a family for a long time, or things left unsaid. And when we can help people to get to the point where they can express that and then be able to talk about it amongst other family members, we can help them to come to a more peaceful resolution. And that's only going to be a good situation for them and for their loved one ultimately.
Right, right. Yes, you want them to be at peace as well as the person who is in this situation.
We don't want family members ever leaving the hospital with that doubt in their mind that did they make the right choices? Did they walk away and give up too soon? So sometimes it takes a while for things to progress, for people to get to that place where they can either let go. But we've also seen cases where we think that somebody may not make it, and then actually they do recover. So you always have to weigh the possibilities that there's something bigger in this that we don't always know. We give the best information we can always provide, but there's something bigger than us that is overpowering the situation. And a patient's desire to fight through can make a difference.
One of the things that I was struck, I read the book, and one of the things that struck me was how quickly the children, if you will, had to start talking about this. That, one person had to travel halfway around the world to get to the father's bedside.
Yes.
And before you know it, I mean, maybe a couple of days had gone by, but not too many days had gone by before they were then thrust into this decision-making process, which is another factor, I think, because you've hardly come to grips with the fact that the person is ill, and now you have all these other decisions to make.
Right.
So you've seen that happen? I mean, is there like a timeline or a timetable?
There really isn't. It depends on every circumstance. Everyone is unique and different. We can have people who can come into the hospital and it's pretty evident that either this is a catastrophic event, whether it's a brain bleed or a heart attack, that this is not a recoverable event, and that there is nothing that we're going to be able to do to prevent this person from passing away. To present that to a family in that situation is very difficult because the shock of it, that how could this just happen? we were talking this morning at breakfast, and it's now dinner time. How could things have changed so dramatically?
Right.
And yet we see that that does happen. Other situations can unfold over time, so that it can take several days before we actually know whether there's going to be any possibility of a reversal of the situation. So we watch and we try to maintain them as best we can, and we continue to do testing to see whether or not there's any changes. After several days, it can become evident that there's not going to be any possibility of change, and that's what happens in this particular story. Because it's a brain injury, it's pretty evident that this is not a recoverable event. And yes, they could maintain his body and bodily functions, but we're not really saving his life at that point. And that's one of the things that I spend a lot of time in helping families recognize, that there becomes almost an invisible line in the sand where up until that point we are doing everything we possibly can to save someone's life. But when we cross that line, we may not be doing that anymore. We may only be prolonging their dying process and prolonging their suffering.
But you're not really sure where that happens.
No.
Right,
No.
right.
It's very individual and unique for every situation.
Right, and also in the book, one of the characters held out hope, because every now and then you hear a story about somebody who had a catastrophic brain injury, and then, 10 years later, they seem to recover miraculously, and so people hang on to that as well. So I don't know how you address that. Does that ever come up?
It does. We've all heard stories. They've all been in the news and in newspapers that people have heard about, or the internet, and people go online and they do a lot of research, as they should. They should be informed consumers of a product, which is healthcare. But those stories are also unique and different, and the circumstances can be very different. When someone says that someone was in a coma and then they woke up, those circumstances might be vastly different than someone who's sustained a severe brain injury that it involves the brain stem, and that this is not a recoverable. If they were truly brain dead, then the person is not going to recover. So the circumstances are different.
Okay. Let me just ask, do you feel that there's any kind of pressure on people to make a decision, people who are facing these decisions? Do you feel there's any, or for that matter, people as they're filling out their healthcare wishes, their forms and whatnot, do you feel there's any pressure on them to refuse life-saving or life-sustaining measures, or is there a pressure to let's move past this? Does society put any pressure on people to do that, or do families?
Well, putting pressure on someone to make a particular decision would be unethical. It would be violating an ethical principle called autonomy. Every patient who has the capacity to make a decision for themselves will be given that right and the authority to make the decision about what they do or do not want. And we will do whatever a patient wants. It may not be what we would recommend for this patient, but if a patient wants to continue to have services provided to them, we would always honor that.
Okay, and even if it's done through the proxy or the
Absolutely.
guardian.
But we do make recommendations when we feel that going forward to do something to a patient could be more harmful than beneficial to that patient, then we would be honest, and it's called informed consent. So we have to make sure that whenever we're presenting anything to a patient, that we do a really wonderful job about giving them all of the options, all of the information, so that they can make the best decision possible about their care. And the same would be true for their family members if the patient themselves are not able to speak on their own behalf at that time.
Right. Let me just ask you a couple of quick questions. Do you see any trends among people of various faiths, or trends among people who are healthcare workers versus non-healthcare workers? Do they have, it's other guiding factors, I guess, that help them make their decisions that maybe some other people don't?
That's an interesting question. I've been witness to a variety of decision-making processes, And I don't think that just because you're in healthcare that you automatically would say, I don't want anything done. In fact, I've seen families who have physicians and even nurses in the family, and they can be the most challenging because they want everything done because they're aware of all the things that could potentially be offered to their loved ones. So, and then we've had others that come in and they say, no, I don't want my mother to go through that. I don't want you doing CPR on a frail little person who's, it's not going to be successful, and I know that. So I wouldn't want you to cause additional harm to her in the last moments of her life. I want to provide her with the most peaceful passing possible. So, but it depends on each individual person. I can't say that there's a trend one way or the other.
Okay, all right. I know we've got a couple more things that we want to talk about. One is this, there's a form called a MOST form.
Yes.
Can you talk about that in brief terms or general terms?
Sure. MOST is an acronym for Medical Orders for Life-Sustaining Treatment, and it's a new form that is here in the state of Massachusetts. In other parts of the country, it's called POST, or Physician Orders. MOST is designed for you to sit down with your physician once you have been diagnosed with a life-threatening illness, like COPD, or any type of metastatic cancer, any type of heart condition, anything that is going to limit your life and potentially end your life.
Okay.
So you're to sit with your physician and you're to fill out this MOST form. And the MOST form actually asks you specific questions about what your wishes are should you get to the end of your life or be in a situation where you may need to be put on a respirator to continue breathing. Do you want us to do that? And so you would go through that form, and that becomes your form for you to keep, but you're to bring it with you every time you come to the hospital, and it becomes part of your medical record, so that we have that information up front. And you've had the conversation, which is really important, to talk to your doctor about, would you want to be on a respirator? And it's not a yes or no sometimes. Sometimes it's, I would want to be on for a few days to see how I do. But after 3 days, if there's no change, then don't keep me going for a long time. Remove me, let me go in peace.
Okay, and this is different from a living will in which way?
It goes in conjunction. The living will really spells out what your preferences are, but it also names a healthcare agent for you, someone to speak on your behalf should you not be able to speak on your own behalf.
Okay, okay. All right, so anyway, so this is something they would do with their doctor?
Yes.
It's a form that they would do with their doctor.
And it becomes a medical order.
Okay, it's a medical order that they would discuss with their doctor when they have a chronic illness.
Yes, it's not for anybody. You have to have been diagnosed with a chronic life-threatening or life-limiting illness in order to sit down and fill out one of these forms.
Okay, all right. Okay, well that's good to know. So that might be, just so people are aware of that. And it's MOLST is the form, right? So people can look that up online if they want more information about that.
Absolutely. So there is another project that comes out of Boston that was started by Ellen Goodman, who's a columnist for the Boston Globe. And it began after her mother became critically ill. And Ellen was being asked to make these kinds of decisions and realized that she had never talked to her mother about what her mom's preferences would be. And so after her mom passed away, she began something called the Conversation Project, and it's become a national organization right now. And they really do go out and promote people having the conversation, and they have all kinds of online tools to help people sit down and talk about it, and talk about what questions you want to discuss, and how do you go about getting the forms and fill them out, and where do you keep the forms, and how do you access them. And our program is linked into her website. And we're also, because of that, we're now being linked into all of the organizations throughout the United States that are attempting to do these kinds of conversations so that we can share information and share resources and ideas, which is a really wonderful opportunity for us to be part of that.
Sure. So this is something that you basically started here at Lowell
Yes.
General, and it's now taking off nationwide.
Right.
And this conversation is happening
Right.
all over around this book.
Right.
Yeah.
It's one of the most important things that we can do as a population, because we are aging in this country, and so we're going to be facing more and more of the baby boomers as they get older, having to face that our lives will come to an end. Most of us don't like that. I remember the first time somebody said to me, "You're going to die," and thinking, "Oh no, that won't be me." And I think a lot of us walk around believing that. But the reality is we will come to the end of our life. How we choose to end our life, if we have that opportunity, is really important. And we have the obligation, I think, to our families to tell them what we want or what we don't want, to make it as easy and as comfortable for them as possible.
So now, so you've got this conversation started at the hospital. And what about joining in if you wanted to read the book and become part of one of your book discussions? Do you have to be part of the hospital
You do not.
community to join in the conversation there?
No, we want to get this out to as many people as we possibly can. So you can go to your library and get the book. The libraries locally have been connected into this. You can go to our website and get information. There's even a survey on our website that after you've read the book that you can fill out to give us further information as to how it went in your family, whether you've had the conversation or what prevented you from having the conversation, and how can we help assist you in doing that, because we'd like to make it as easy and as comfortable for people to sit down and have the conversation as possible.
Okay, and you're going to be running this program indefinitely, or do you have an end time for this?
We kicked off this program on April 16th, which is put aside as National Healthcare Decisions Day. It's the day we really promote throughout the country having people fill out their advance directives. And so we will probably be offering an additional program or workshop in January, and then we'll conclude the program in April on that day. And we don't have formalized plans for how we will conclude the program at this point. But if it's successful, this program could continue.
Okay, well, I think we're going to have to leave it there.
Okay.
We've covered a lot of information here, and I want to thank you for your valuable information, your contributions to our education here, and getting this conversation started. And I want to congratulate you, too, on getting this program going.
Thank you so much, Connie.
It's great, and I want to thank you all for joining us this evening as well, and tune in again next time. Thank you.